You're right. So now we're going to get into the mechanics. I've got a feeling here.
Yeah. So we prep. We have some patient prep, and for FDG scans and for amyloid plaque, they're very different. Okay. So I'll try to go through this pretty quickly here. So with FDG, obviously we're going to wear comfortable clothing. Our caregiver usually can accompany the patient sitting in the room before their scan, during their scan, but different nuclear medicine departments kind of have different rules. So you can kind of ask if you can come in with your loved one. Sometimes they'll say yes, sometimes they'll say no. So try not to get upset if they don't want you in the room, but different departments are going to have different rules, okay? The patient will have to lay down for about 10 minutes on the scanner and hold still so we get good images. No jewelry around the neck, head or neck. We want to make sure you use the bathroom beforehand so you don't have to get up and go to the bathroom. Before you arrive for your scan, you have to be fasting 4 to 6 hours, so you can't have anything to eat. They want you to hydrate well. Make sure you drink some water, okay? You want to avoid caffeine, alcohol, and any drugs that could affect the metabolism of the brain. They say you can take your medication. And then if you'll have an intravenous infusion of dextrose, has to be withheld for 4 to 6 hours. So this would be more of somebody who's in the hospital setting, or they may have an IV, but if as an outpatient, you're not going to have that. And then pre and post injection, they're going to measure your glucose to make sure your glucose isn't too high, because that's going to affect the uptake of the tracer, which could kind of miscue the results for the physician. So he has to make sure your blood glucose isn't too high. If it's over 200, they will reschedule the scan, okay? Because that means too much normal sugars circulating around, and then the radioactive sugar that we're injecting not going to go to where it needs to go. So that's really important. So don't be upset that it has to be rescheduled. It's because we want to get a good quality scan, okay? From an environment perspective, this is really interesting because light, noise, sound affect the uptake of the tracer that we inject, because our brain is always processing things, always using sugar to process things. So when we look at something, right here, you see the picture in the right-hand corner here. When we look at things, our brain is active in certain areas. When we think about something, our frontal lobe may be more active and it's going to pick up tracer. When we remember things, a different area of the brain is working there. It's going to have uptake. When we work, we do things. When we listen to music, all those areas of the brain is functioning and picking up tracer. So when we inject FDG, we inject it in a quiet, dark room. Okay. You can't look at your iPad. You can't read the paper. They don't want you to talk, because all those things stimulate the brain, and we want kind of an even keel so the radioactive tracer can go where it needs to go. One of the interesting things that when I first learned about the FDG is if you close your eyes while you're getting injected, that's going to give you an abnormal result in the back of the brain. Because remember, we talked about the occipital lobe with Lewy body dementia. If you close your eyes when you get that FDG injection, it could simulate inaccurately hypometabolism in that occipital area of the brain. So it's real. FDG prep and injection and being quiet in the room is really, really important. And then they'll do that. It'll let circulate for about 30 minutes or so, and then you'll get your 10-minute scan. Amyloid imaging is very different. So
before you move forward, Barbara, let me do a quick recap here. So we're talking probably about 45 minutes in a quiet, dark space where you're awake, but you're not doing anything and you're trying to be still. So you are not initially lying down. But then
you're usually sitting in a chair. Most injection rooms, or you sit in a chair, they'll start the IV in your arm. They'll let you sit for a little bit, and then they'll quietly come in, give you the injection, and then they'll go away, and then they'll let it circulate, and then come back and then put you on the scanner.
Now, do you keep the IV the whole time you're in the scanner?
Once that, yeah. I would say listen to the instructions of what the technologist tells you. At that point, everything's kind of circulated where it needs to go. So you may be able to close your eyes if you want to, but I would definitely check with the technologist who's doing your scan. So each department may have a specific rule that nuclear medicine physician likes to follow. So just ask if you're not sure. Just easiest thing to do is ask, so then you know you're following the right instructions to get the best test that you can get.
And I think that's the thing is like if I am having symptoms of dementia, it is highly possible I'll forget the instructions while I'm lying there. And it's one of those things, I'm sure that when people get trained, one of the things you say is if people ask a question, it's not because they're being ornery. It's really, what they're showing you is one of their symptoms is, so how long am I going to be in here? And you've already told them several times, that it's going to be about 10 minutes. And, they're really finding that 10 minutes feels like forever.
Forever, yeah. It does. And what we have some pictures here that I'll show you in a few minutes, what the scanner looks like, how you're going to be positioned under the scanner, what the workstation looks like. So when the technologist leaves the room, yes, he's leaving the room, but he's not leaving you. He's operating the equipment. He can see you through a window. So you're really not by yourself. And you know what? Every single technologist that I've ever worked with, or me as a technologist, if I had to repeat myself 10 times so you understood and you felt comfortable, then I'm going to repeat it 10 times. We know there's cognitive issues. We know why you're here for your scan. So if you ask me, how long is my scan? 10 minutes. And then 2 minutes later, you ask me the same thing, I'm just going to tell you again, so you feel comfortable. That's what it's about. Us making sure you're comfortable getting your scan so we can get the best information for your doctor to make the right decisions for your care. And that's the most important thing.
Yeah. And I'm thinking, Barbara, this kind of scan is that FTG scan is more commonly done. Is that accurate? And then the amyloid scan is the one that many people, that would be a little different. That was different. You're going to tell us about it. And it's done when we suspect, or people are thinking we want to rule out, we think it is Alzheimer's specifically. Is that or not?
The FDG scan's been around longer. Okay. So prior to us having an amyloid scan to look for amyloid plaque, what the physicians did was they looked for a pattern of hypometabolism to say, oh, I think you have Alzheimer's based on the pattern of FDG uptake. Where now we actually have an amyloid scan that says amyloid positive, amyloid negative, okay? And then that helps them tell. So even now, different physicians have different philosophies of I've heard some physicians are like, nope, I just use FDG, it's available, it's less expensive than an amyloid scan. And then I have other physicians that are like, nope, we believe in amyloid imaging and we do amyloid imaging. So there's still physicians picking different studies based on what they're comfortable with and what they feel their patient needs. So
cool.
And both provide information. So who knows? I mean, I'm not a physician, but you could even get both of those.
Yeah, that makes sense as well. Cool. So tell us about the PET scan. With the amyloid.
So with amyloid, PrEP is very different because we're looking for amyloid plaque burden in the brain, right? So it's either going to be there or not be there, right? So light, noise, and sound doesn't affect the uptake of my tracer. It's either going to be there or not there. So you'll get an IV started in your arm. they'll inject the tracer, and then there are 3 tracers on the market. So different imaging centers may use one of the 3 available, but you'll get it injected, and then you'll wait anywhere from 30 to 130 minutes after you've been injected, depending on the protocol that the department is using, the tracer that they're using. But basically, you'll get injected, you'll wait a period of time, then you'll get under the PET scanner, you'll be positioned under the scanner and get a 10 to 15, 20-minute amyloid scan.
Okay.
Positioned the same way as an FDG, just a different tracer, looks at different things. So with the amyloid plaque, amyloid scan, you don't have to be in a quiet, dark room because your amyloid plaque burden is already there. Okay, so we're just injecting, seeing where the amyloid tracer goes, and then taking a picture of it. So
yeah, so if I have somebody who tends toward really needing to be busy and really needing input in order to stay still, and then this might actually be something to say, you know, I wonder, doc, what's the difference between this one and this one? Is this one that I'm curious about? Because given my husband, I think we're going to have a difficult time with him not having anything to eat or drink for, 4 to 6 hours. And his blood sugar tends to be variable anyway, because he also has diabetes, and we have a hard time managing that. And I'm just wondering, what do you think about, and it is actually, as an informed consumer, I could at least ask the question and then listen to what the doctor has to say. But
exactly,
I mean, rather than trying to sedate him, recognizing he is who he is, and we're really looking at, is this what we're looking at? I mean, if this is what I've got on my hands and what he's got in his life, then we need to learn to cope with it. And so, that's really what we're learning. So, okay, cool. Thanks.
So then here again, you'll remove jewelry, things like that. Again, sedation can be used if the patient's really anxious or whatever, just to make sure we get a good scan. And that's why we do it. And then again, we want to make sure you go to the bathroom before the procedure, so you're not wiggling around on the scanner, and then we get blurry pictures because you're wiggling around. So, and believe me, you do wiggle around, because I've had another PET scan or a nuclear medicine scan myself, and I had to drink a lot of liquids. And toward the end of my scan, I'm wiggling around. So make sure you use the restroom before we start our scan. So again, it's a 5-step process to go through a amyloid PET brain scan. So the first step, roughly the whole scan takes about 2 hours, start to finish. Okay. You'll get an IV started in your arm. Okay. The technologist will inject the tracer for the amyloid scan. Okay. And then again, it'll circulate anywhere from 30 minutes, like I said, to about 130 minutes. And that depends on what tracer the department uses, how long their doctor wants the tracer to circulate, and things like that. So just know they'll inject you, it'll circulate for a period of time, okay? And then you'll go under the scanner. Second part, you get positioned under the scanner. The technologist here will position you with a cushion probably under your knees. So if you have problems with your back, hopefully that'll alleviate that. There's a little body strap here you can see hanging down. They'll put that over you so you feel comfortable and you're not going to fall off the edge of the scanner, because it's a really narrow, what I call trough. You kind of lay in, it looks like this little trough. So to feel comfortable, like you're not going to fall off, they'll put the body strap around you. Okay. Then what they do is they put your head in a head holder. And this sounds like a lot, but we want to make sure your head is as still as possible for the entire length of the scan, okay? So they'll put your head in this head holder. Sometimes there'll be a little gap in between the head, the patient's head, and the head holder itself. And they'll put maybe like a little cushion in between the head and the head holder. So you feel something against your head and you'll remember to hold still. So that's why we'll do that. And then once we do that, the next thing we do, and I know it sounds like a lot and a lot of people don't want to do it, but it's really important that the technologist, that you allow the technologist to do this, is use a chin strap and a head strap to really make sure we hold the head still, because any motion, because remember that gray matter that we talked about is only 2 to 4 millimeters thick. And if there's a little bit of motion, it's going to blur that area, and then the doctor can't see the differences in that white matter and gray matter. So the chin strap's important, the head strap's important. You may say, oh, I can hold still. I promise I can hold still. We really want to make sure, because if we don't and you move, then we have to start the scan all over again. So it's easier to try to do it right the first time with the chin strap, with the head strap, to get great pictures for the doctor to read and your physician to have. So
yeah, and the only thing I'm going to say while y'all are looking at the pictures is that gray thing across the eyes is to make sure you can't identify who it is. They don't put something over your eyes. It's just so you know.
Yeah, sorry. Yes.
No.
Yes, that's actually. Yes, that's actually just a privacy thing. That was a technologist. I actually know the group of people in these pictures. I was the one that took the pictures. So yes, that was a privacy thing. That was a technologist being nice for me and taking some pictures for my presentation here. So here's the picture of the workstation. So once the technologist sets you up under the scanner, they're going to get you comfortable. They're going to say, okay, you're positioned. I'm going to leave the room, and they're going to come sit in front of this computer screen. And 99 times out of 10, this is exactly what the workstation is going to look like. They have a little speaker. They will talk to you. They can see you. If you say, John is your technologist name, John, I need you, or John, he can hear you. He'll press the button and he can answer you. But the most important thing is for you to hold still during your scan. But they can see you, hear you. They might come on the speaker and say, oh, you're doing great. You got 5 more minutes to go. Some people will do that. Others don't. And if you feel like you want to know, hey, how long do I have? Just say, hey, John, how much longer? But make sure you hold your head still. That's the most important takeaway from.
And I'm betting the other thing that you need to remember to do is breathe. Because as you're having all this happen, it's one of the tricky parts is keeping your breath sort of smooth, because it's easy to start holding your breath in these situations when you're feeling sort of like, ooh, God, here it goes. Okay. And it doesn't feel like anything much is happening, but you're still starting to get anxious. And so that idea of just keep breathing, you're fine, keep breathing will also help you hold still, because you'll get oxygen. And it's always a good idea to get oxygen.
Exactly. Yep. So then once the scan's done, then what happens? So again, we talked about motion. So we want to make sure we're using that chin strap. We want to make sure we're using that head strap. If there's motion, it needs to be repeated. Okay. When I teach technologists, so once your scan is done, what they'll do is they'll pull it up on the scanner and they'll review it for quality, and they look for patient motion and things like that. If there's patient motion, they're going to repeat your scan, because the worst thing we want to do is give the nuclear medicine doctor not the best quality scan, because then his report to the neurologist is not going to be the best quality report. So it's real important. If there's motion, they're probably going to repeat the scan. So make sure we do that head strap, chin strap, and we'll do it once and we'll get good pictures. So once the scan's done, again, we talked about what do they look like? They're either going to be categorized as beta amyloid positive, which is this bottom row here that we talked about, where all the curved edges are all smooth, all the nooks and crannies are all filled in, right? That's a positive scan. And then a negative scan is the one on the top. Both are very useful for the doctor. You know, obviously, like Teepa said, we'd all really like a negative scan just so we know there's no amyloid plaque in the brain, but it still gives the physician information on how to treat you and what to treat you with and things like that. So positive and negative is what we're looking for and how they're read. Okay, whoops. So there are some limitations and some risk with any nuclear medicine tracer that we inject patients with. A positive NeuroSeq scan does not establish the diagnosis of Alzheimer's or any other cognitive disorder. It just says you have plaque, okay? Then like I said earlier, the doctor takes all the information he has. He takes the results of your scan. He takes your clinical symptoms. He takes your MRI, whatever he has, puts it all together, then says, based on everything we know, this is what I think your diagnosis is, okay? So that's important to know. The safety and effectiveness of NeuroSeq hasn't been established, so we don't predict the development of disease, okay? And we don't currently monitor therapy. So if someone's on some kind of therapy or some kind of medicine, we don't do this scan to say, okay, take this medicine, we're gonna do a scan at the beginning, and then we're going to do a scan a year from now. That's not in the package insert clinical indication for an amyloid scan. Okay. So, and then risk.
But Barbara, right off, I will say one real quick thing. Yep. There are researchers who do clinical trials that are doing this kind of trying to get this to this place.
That is correct.
So this is an important thing that if you choose and you want to be part of this front end, this is a place where there is work being done. So it's just, this is not for physicians and patients who are in established practices. However, it is something that is starting to be done and has been done for some time now, really working toward this. So I just didn't want to leave that out there. But now you can
that's actually correct. So the limitations and risks that are here are in the package insert of the protocol that got FDA approved. But when we talk about clinical trials, that's totally different and separate. So like you said, yes, there could be if someone was involved in a clinical trial, but this is just basic, anyone using the amyloid tracers for a commercial reason, not in a research setting. So depends on what setting you're in. If it's just a regular commercial use of it and you're following the package insert, we kind of do one guideline. And then if it's clinical research, obviously then that clinical researcher can do whatever he wants, and monitoring those therapies could be one thing he might be interested in. So thank you for pointing that out, Teepa. And then risk, obviously, any nuclear medicine, radiopharmaceutical, radioactive tracer that we use or a patient gets injected with will contribute to their exposure over time. And there is research that says long-term radiation exposure is associated with increased risk of cancer. I mean, we all have had some kind of scan, a chest x-ray, a CAT scan, all that, you know, a PET scan, a nuclear medicine scan, all those contribute to the overall risk of anyone getting cancer. Flying in a plane, you get exposure radiation at high altitudes and things like that. So when the technologists handle the radioactive tracer, they protect themselves and they protect you. So you'll see them carry the injection in this big lead container. They take it out. There's this big lead thing around the syringe. You saw that in the picture. That's important. That's important. Looks a little scary, but it's important because it protects you from the radiation and it protects the technologist from the radiation. Okay. So, or undue radiation exposure. So you're going to get exposed just because you're having your scan, but undue radiation exposure, we practice that. We make sure it's safe for everybody. And then the dose that you're going to get is 8.1 millicuries. That's how we measure it. So we want to make sure you get the exact amount you're supposed to get. And then the radiation exposure is 5.8 millisieverts. It's just a way that we measure the radiation exposure. That's really, you don't really need to know any of that, but it's important that it's there, that you know. CAT scans, X-rays all have radiation exposure associated with that, and it's measured in millisieverts. And each procedure has a different level of radiation exposure. So then we follow up. So what happens after you've had your scan? You did really well. You didn't move. You only had to do the scan once. The nuclear medicine physician will read the scan. Okay, usually takes a day or two, couple days. They'll dictate the report, and then the report gets sent to your doctor. And again, a positive scan means you have amyloid plaque, okay? And a negative scan means you don't have plaque, okay? And that means that your cognitive impairment is not due to Alzheimer's. It's due to something else, like Teepa was talking about earlier. It could be frontal temporal dementia. It could be vascular dementia. It could be Parkinson's disease or any other kind of neurological condition. But if you don't have plaque, then that means your cognitive impairment is not due to Alzheimer's. So that's really important, because a positive scan is going to have the physician go one way with treatment and care versus another way if it was negative versus positive. Okay?
And it also doesn't mean, I mean, just to be real clear, because we know as people you could have mixed picture dementia. So what it could show you is you have Alzheimer's, but you keep showing symptoms that are not consistent with Alzheimer's. Then our brain would say, well, but you have beta amyloid. It's like, you sure do, but it looks like you might have something else cooking too.
Right. And then that's where that doctor might pick a different kind of scan, you know, to see. And one of those scans could be a DAT scan study looking at essential tremor versus Parkinson's disease versus Lewy bodies. So, you know, it's not kind of one set of pictures and you're done. It could be, okay, we know you don't have Alzheimer's because you have a negative scan, but like you just said, something else still could be presenting itself that's he's not getting a good picture. He might order another type of scan, like a DAT scan, to say, okay, what is that showing me? And then that tells him a different path to go. So it's all very important, helping patient management decisions.
Yeah. And earlier, better. So
earlier the better.
Earlier the better, because then we're on the right road and we're making good choices on that road.
Yep.
So
exactly.
Cool.
Exactly.
All right.
Okay. Then, so there's kind of two different doctors in your care, right? So you have the doctor that orders your scan. That's your neurologist, your dementia expert, whoever you're seeing. He's going to order the scan based on how he feels, what he feels he needs to help take care of you. And then we have the nuclear medicine physician, trained radiologist, who actually reads your scan, okay? Your doctor is going to make all those clinical decisions with you and for you based on the scan results that he gets for the different scans that he's ordered, blood tests, all those things. Your doctor is going to make those decisions. The nuclear medicine physician just interprets the scan and sends a report to your doctor.
Cool. Whew. So
that's conclusion for part one. So we're not there. So we're going to skip ahead here to two. We have a couple bullets, real easy. So we've learned that the PET scans and the results are a very important piece to help guide patient management decisions for physicians, patients, and their families. So these scans we are doing are very important, okay? Understanding what you go through. So hopefully I was able to ease your mind a little bit with the scanning process, because if you don't know, you do get anxious. I mean, I would get anxious if I was involved in something that I didn't know anything about, and people are poking you and prodding you and telling you to hold still and things. So hopefully I was able to show you some pictures that made it a little bit more comfortable. If your doctor is interested in doing a scan like this and you're really anxious, I've even heard of patients, caregivers calling the imaging center where they're going to have their scan and say, hey, can I come in? Can you show my mom the scanner? You know, the doctor wants to have one of these scans. And if they have time, I've heard that imaging centers will do that because the scan's expensive, the tracer's costly, right? So they don't want you to get injected, get under the scanner and go, I can't do this. I can't do this. So we'd rather make sure you're comfortable, make sure, you know, we're all going to be anxious a little bit, but we want to make sure you can get through the scan and then we get a good scan for your physician. And understanding Alzheimer's disease and what causing it helps the patient and their families manage their care better. And Teepa, I think you said it's like the earlier the better. So the patients involved in their care, they can get into clinical trials earlier. They can have a better quality of life instead of waiting all the way to the end and then finding out and then they really can't do anything. So the earlier the better, and definitely the scans can help that decision-making process.
And what I'll tell you is, Barbara, you were super helpful. And you're putting up the slide that comes next, which is, if after you watch this courageous conversation, you have questions, well, when we put it up, you have the opportunity to interact with the video that we put up and send those questions in on our Facebook page. When you do that, guess what we'll do? We'll be getting up with Barbara to say, hey, Barbara, we got some questions. And we'll ask those questions, because the way we get better at this stuff is we work with one another, because frankly, that's the only way we're going to figure all this out. So, wow, Barbara, thank you. You did a phenomenal job of dealing with lots of information and lots of questions from me. And I want to say thank you for our folks out there who have the potential to make different choices or better choices based on having the courage to ask questions and taking the time to listen in. So thank you, Barbara.
Awesome. Thank you so much, Teepa. Take care.
You too.
Hi, I'm Teepa Snow, and you just found our YouTube channel and watched one of our videos. I'm the owner and founder of Positive Approach to Care. Thanks for watching. And if you liked, if you have a comment about, or you would, please share it with people you know. Oh, and if you haven't yet done it, consider subscribing. We'll let you know when the next new video comes out. And you might want to visit our website, www.teepasnow.com, where you'll find other resources as well. See you there.